Hello and welcome to the Mesothelioma UK interviews. I'm glad to say we're continuing with these interviews and we hope that you're finding them helpful. I'm Lorraine Creech, Head of Nursing at Mesothelioma UK, and today I'm joined by Dr. Alex Haragan, who is a pathologist at the Royal University Hospital Liverpool. I think it's safe to say that there have been many developments over the last decade in the treatment and diagnosis of many cancers, and so we're still in a changing landscape, and things continue to change all the time. But one of the major ways going forward has been how we use biomarkers in diagnosis, and how this has helped lead to the precision medicine of the right drug at the right time for the right patient. Would you say it's fair to say that?
Absolutely. Stratified medicine is exactly what you say. It's about finding specific targets, specific areas for which a particular cancer, a particular subtype of cancer will respond more or less favorably to specific treatments. And our only way of knowing whether those treatments will work before we give a treatment is to look for these biomarkers, as you say, and these vary from case to case and patient to patient and treatment to treatment. And what we're really looking for is something that can provide us with as much accuracy as we can do, because ultimately this allows us to provide us with treatment that will work, and not give people treatments that are not going to work, A, but also deny them another treatment which might be better, B, and C, of course, all treatments have side effects, and we'd like to minimize that as well.
Good. We're going to focus today on PD-L1,
Yes.
and we're talking to a large audience, various backgrounds. Can you just tell people what PD-L1 is, please?
Sure. PD-L1 is very close to my heart. I've been studying it for many years, so stop me because I will talk for days. But basically, the easiest way to think about it is its reaction between cancer cells and your immune system. And it's a normal part of our immune system, in that if you imagine, so just stepping away from cancer for a moment, if you just imagine a normal cell in your body, a virus infects it, and one of the things that can happen is the immune system will target that cell for destruction, because it knows there's something wrong with it, i.e. there's a virus in it. And one of the things that can happen is a particular kind of white blood cell, a T cell, names aren't too important. What matters is that this can latch onto that cell and kill it, because it knows that the cell has gone wrong. And in a very, very similar way, that's what's happened with cancer cells. So as I'm sure you're aware, a cancer cell is essentially a normal cell in your body that has gone wrong. And it's gone wrong this time because of mutations. The more mutations that a cell has, the more likely it is to become a cancerous cell. Some of those mutations won't do very much for it. And other mutations means that the immune system is more likely to recognize it as a cell that's gone wrong. So it's more likely to target it and say, okay, this is a cell, it should be destroyed. And the amount of mutations is an important point for mesothelioma. I'll come back to that later on. But for PD-L1 specifically, in essence, in everything that happens in your body, there are stops and balances, there are different checks, there are go signals, there are stop signals, and that's to stop any one thing in your body from overreacting. So these killing T cells, these killing white blood cells, they're very, very potent, they're very good at their job, but in order to protect our own body from some of its side effects, normal cells in your body might express PD-L1, and PD-L1 is essentially a brake. It's a big stop signal to these killing T cells. It basically says, no, you can't kill me. And in essence, there are many different ways in which a cell might tell the T cell to not kill it. PD-L1 is one of these. It's a very big one. And so coming back to cancer then, we have a cancerous cell, and it typically has many mutations, and there's an immune response targeted against it. In other words, your immune system is trying to clear it like it would do with anything that's gone wrong, but it also has PD-L1 being expressed. That means that the immune system is stopped. It's put in limbo, and it is unable to kill the tumor cell, if that makes sense. Mm-hmm. Good. So basically then, what we know is that there are various different ways in which cancer cells can stop it. PD-L1 is just one of them. So when we look for PD-L1 as a biomarker, as we were discussing, to see whether particular treatments would work or not, what we're essentially looking for is this tumor, are these cancer cells using PD-L1 as an anti-immune response because it has lots of PD-L1, or is it not because there isn't very much PD-L1? And that, to us, broadly speaking, will make a difference on whether these therapies are likely to work or not for any one given patient who happens to have a cancer which does or doesn't have PD-L1.
So do you want to say something about immunomodulatory therapy, or do you think you just covered that, or would you like to say something?
No, I'm happy to. So immunomodulatory therapy is a very broad term. It covers lots and lots and lots of different therapies in and outside of cancer. What I'm talking about today specifically are what we call these inhibitors. So, and I apologize if I'm overcomplicating this. I'm trying to make it as straightforward as I can, but it is a complex area of biology. It's a basic principles. We have a cancer cell here, and we have an immune cell trying to kill it. And we basically have an immune cell being told no by the cancer cell because PD-L1 on the tumor cell is talking to it. Okay. So the immunomodulatory therapy in this context, what we call immune checkpoint inhibitors, the names aren't too important. What we're essentially doing is we're either targeting that PD-L1 protein, or we're targeting its receptor, PD-1, starts to get confusing with the names, which sits on the white blood cell. And either way, even if you're disrupting PD-L1 or its receptor PD-1, in both cases, what that allows is the immune cells to be reactivated, and it allows them to successfully kill the cancerous cells. So in this context, what we are talking about in immunomodulatory therapy is essentially removing the brakes from the immune system, getting the immune system back on, up and running, and able to kill these cancer cells. And why we look for PD-L1 is, as I say, there are different brakes, there are different ways in which tumor cells might be stopping these. So looking for PD-L1 means that it's more likely that these drugs will work. But unfortunately, it's not as straightforward as that, because there are lots of other considerations we need to take into account when we're considering whether these drugs will or will not work.
Mm-hmm. So that's why PD-L1 makes a difference, really.
Absolutely.
Yeah, that's great. And what treatment options are there out there, would you say?
So in regards to this area of immunomodulatory therapy, there are essentially three kinds that are validated for use in all cancers. We basically have ones that target PD-L1. We have ones that target PD-1, so its receptor and its thing. And then separate to that, but working in a similar way, is something called CTLA-4. They've been around longer, actually. And CTLA-4 works in a very, very similar way. Its presence basically inhibits and stops these immune cells from being able to kill the cancer cells. So if you disrupt CTLA-4, then the immune system is able to come back and kill the tumor cells. So those are, broadly speaking, the different options. Now, I'm going to talk a little bit about the treatments in regards to lung cancer, not mesothelioma, non-small cell lung cancer, which is the commonest kind of lung cancer, because this is one of the areas where we've seen a lot of these successes. Mm-hmm. And there's essentially three ways in which you might try and give these drugs. By themselves, in combination with more traditional anti-cancer therapy like chemotherapy, or in combination with each other. So you might give a PD-1 inhibitor with a CTLA-4 inhibitor, for example. And that's also quite relevant for mesothelioma. Separate to all of this, and this is a point I want to talk about for mesothelioma specifically, is mesothelioma, as we know, is something that has often not done very well when these new treatments come along, exciting treatments come along. Other cancers seem to be responding brilliantly, and mesothelioma, it isn't. And one of the big problems of mesothelioma is it's twofold. The first is that, when I mentioned earlier that the more mutations that a tumor was likely to have, the more likely the immune system would notice that there was something wrong. Now, that's a really important point, because if there is no immune response happening, then it doesn't matter what of these PD-1 or PD-L1 inhibitors you give, you can't get the immune system working if there hasn't been a response in the first place. Now, separately to that, There are different clinical trials looking at ways of trying to stimulate an immune response first and then give an inhibitor, but that's experimental even in the context of other cancers. So what we know is we need to have an immune response first, and then we need to see that there's PD-L1 happening in terms of a defense mechanism that the cancer is using. Now, mesotheliomas tend to not be cancers that have lots and lots of mutations. They tend to have relatively low, what we call tumor mutational burden, which is a different kind of biomarker, something that you may have heard about, or some of your listeners may have heard about, because again, that is also relevant for mesothelioma. I'll come on to why that is in just a moment. But essentially, tumor mutational burden, or TMB, is a crude measurement of basically how many mutations does this particular cancer have. So not mesotheliomas or all mesotheliomas, but this specific cancer sitting in front of me is a biopsy I've taken from a patient. How many mutations does this one have? Now, unfortunately, it's quite a complex biomarker because unlike PD-L1, where you're essentially saying it's there, it's not there, and how much is there if it's there. For TMB, we have to decide how many mutations are there, how many are high, how many is enough to decide it's high, how do we measure it, do different specimens provide us with the right information. And in essence, there's no easy or agreed upon way of measuring TMB. But it is relevant because what we know is the higher that is, the more likely that you are to have an immune response towards the cancer, and therefore the more likely these drugs are to work. And we know that's true in other cancers because, for example, high TMB and PD-L1 looks like it's quite an effective biomarker in lung cancer, although I will say some more recent data has unfortunately not shown that to be quite as straightforward either. But recently, quite recently, in America at least, the FDA did approve one of the PD-1 inhibitors for a small group of mesothelioma patients, and that is based on tumor mutational burden. So I don't believe they're looking at PD-L1 in that context. They're just simply saying, are there lots of mutations in there? And what we know is that only a small subset of mesotheliomas will fall into this category, no matter how you're measuring it. Now, that's not in the UK yet, and there are many reasons for that, not least of all that this issue of how we measure tumor mutational burden and the facilities required for that are not in place right now in the UK nationally. Some centres, yes, but generally speaking, no. But that's possibly something to watch out for in the future. The other thing,
we'll catch up with that in the next year or so, would you say, that, you know, the drugs within the trials?
For that specifically, it's really hard to say because one of the problems is that we need to be able to universally measure it. And a change that's happening across the UK, or certainly in England and Wales at least, is that we're moving away from a model in which local hospitals, even big hospitals like in Liverpool, will necessarily be doing all of these biomarker testings. A lot of the genetic tests are being moved to central hubs, where there may be meant to be about 7 or 8 across the country, which will do all of the testing for their local region. Now, there's various good things and bad things about that. I think mostly good. One of the things that will allow is for TMB to be reliably measured in patient specimens. So that's a really good thing. There are always going to be teething issues when you have a big logistical operation like that. You throw, for example, COVID on top of all of that, there have been delays, and some centres are further ahead than others. I think we need that to be in place first, and then we can think about it. Can that happen sometime next year? I think in terms of being able to make that measurement optimistically, that would be nice to say. Whether that will be soon enough for these drugs to be approved for mesothelioma, I think that will take longer because we'll need to have that in place before NICE will approve it. But the thing I think...
Sorry, that's ipilimumab and nivolumab we're talking about, was just been passed by the FDA.
No, that's pembrolizumab by itself.
Right. Okay.
But yeah. You're quite right. You're quite right. The combination therapy is a one of note, certainly. That had a big phase 3 clinical trial successfully, checkmate 743, I think, which basically saw an improvement. So that's again a CTLA-4 plus a PD-1 inhibitor together. And my understanding is that NICE are looking into that, and we're optimistic to have guidance on that, yes, next year sometime. Mm-hmm. And that's a really nice success area because that's one of the phase 3 clinical trials which has done well. Now, in mesothelioma, generally speaking, prior to these results, it was in the same area as a lot of different tumors, and that you saw some initial success in phase 1 smaller trials, or maybe some case studies where an individual patient has responded very well to these treatments. But actually, when you try and broaden this out to a wider spectrum of patients, you start to find that there are issues with toxicity and side effects. It should be pointed out that although these have side effect profiles that are quite distinct to chemotherapy and are maybe slightly more favorable than chemotherapy, they're still very toxic drugs. They still cause lots of problems, and these problems can be life-threatening. So these are not drugs to give lightly. These are drugs that you want to be giving if you're sure that you're going to see a response.
There's no magic bullet, is there, so to speak?
It is, unfortunately not. And when you start combining them together, like they have in this trial, you might see some improved success in terms of the treatment response, but you also see a big step up in the amount of toxic side effects from these as well. And I think that will be something that we'll have to be mindful of as well, because this is a big problem. And when I speak to my oncology colleagues who are prescribing these drugs and face-to-face managing all sorts of different patients receiving these treatments, that's probably the biggest issue they talk about is these toxic side effects of these drugs. They're quite problematic. But it is nice to see finally a phase 3 clinical trial with a novel drug in mesothelioma seeing any kind of success. It doesn't happen often, so it's something to be celebrated, certainly. I think there is another trial that looked at a different PD-1 inhibitor, durvalumab, in combination with chemotherapy. I think that was only from a phase 1 or phase 2, I think a phase 1 study. So very small numbers, but did show some promising early results. And so that, and for example, there's another atezolizumab trial. Basically, there are lots of different trials going on. Mm-hmm. Lots of phase 2s, lots of phase 3s looking at this area. And what's exciting about this is we're seeing success in so many different cancer areas, which we didn't really see with CTLA-4 inhibitors. They were the first of this breed to come along, and they worked very well in melanoma, a kind of skin cancer, not so well in lots of other cancers. PD-1 inhibitors, PD-L1 inhibitors, we're seeing successes in lots of cancers, so it's really exciting. And hopefully, as more of these trials develop, we'll start to see more successes in mesothelioma. But the other point of caution I would suggest for mesothelioma is that there's lots of different facets to consider, but in lung cancer, for example, we know that there sometimes are specific mutations at what we call driver cancer, driving mutations. So in lung cancer, for example, particular kinds of EGFR mutations. Again, the names aren't relevant. What matters is that that's a specific biomarker for a specific treatment, and that treatment is a sort of genetic blockade rather than an immune related one. Now, that's relevant because we know that patients who have cancers with those sorts of tumors who respond well to those genetic drugs don't respond very well to PD-1 inhibitors, so they tend not to do very well. Now, that's not true for all drivers, but an important point to consider with mesothelioma is that it is often associated with a specific mutation which is called BAP1 loss. Now, BAP1 is a tumor suppressor gene, names aren't too important, but what we know is that an awful lot of mesotheliomas are associated with that. Now, at this point in time in history, nobody knows if that means it will be a favorable item in terms of responding to these inhibitors or not favorable. But if we consider that on average, most mesotheliomas have a relatively small amount of total mutations and are more likely to harbor the specific mutation, those are two things that on the face of it would suggest probably most mesotheliomas will not be ideal candidates for targeting with these treatments. And that's an unfortunate reality of the situation. I think when we talk about these approvals, and whenever you start looking for these biomarkers, they're important because it means for a specific patient who has that biomarker, you can be optimistic of seeing some kind of response. Realistically, I think my gut feeling on this is that for mesotheliomas that do harbor these, you can see some beneficial treatment from that, but probably most mesotheliomas won't. And that's not something I really want to sit here and say to you. I want to sit here and say, oh yeah, absolutely, all of them will. But I think we have to temper these exciting outcomes with realism of the fact that mesotheliomas just are, for many reasons, very difficult cancers to treat.
And it's so important to continue with clinical trials, isn't it? Looking at all arms of treatment, and that's forging a way forward in mesothelioma that is relevant and recent.
Well, yes, absolutely. Yeah. I mean, that's a very good point. The fact that there are so many clinical trials in mesothelioma is exciting in and of itself. And what's really nice about this area is that you have the big cancers, if you will, just in terms of sheer volume, like non-small cell lung cancer, for example, or melanoma or breast cancer. And because they affect so many people, I think the mesotheliomas tend to feel a bit left out, and they are in terms of the total amount of funding being spent on their research. It's much smaller. However, that being said, a lot of the successes that come from these other treatments can be applied to mesothelioma if the approach taken is the right one. And we're seeing a lot of that here. So we're seeing, yes, it's a few years down the line, but we are starting to see these trials come through. And it wasn't all that long ago that the phase 3 clinical trial with pembrolizumab failed. I can't remember the specific agent, but I think that was only in 2019. Mm-hmm. But then just here, we've seen another one succeed, and that's really good news. So the more of these you have, pure numbers game, the more of these trials you have, the better the chances you have of success. And I talked a lot about the fact that there are many different ways in which tumors can stop the immune system. There are other, what we call immune checkpoints besides PD-L1 and CTLA4, IDO1, LAG3, TIM3, VISTA, so on and so forth. Virtually all of those are in clinical trials right now. And the way in which these earlier clinical trials are often set up is they'll often take many different cancer types and see which ones respond before doing bigger trials looking at a specific cancer type. And I think it's fair to say that mesothelioma is often getting included because any sort of response is a good thing. So we're seeing lots of this now. It's a really exciting area. The changing face of cancer treatment right now is really, really exciting. And in lung cancer, if you go back to sort of 2007, say, mm-hmm. there really wasn't much to do besides give chemotherapy. And in that period of time, a little over a decade, suddenly the choice we have before us is astronomical, and we're going to see that increase in volume. So these trials are going to come thick and fast.
Our fingers crossed.
Absolutely. So I think that trickles down. I think mesothelioma, just because of, as I say, various different traits about it, means that on average, if you see X amount of % success in lung cancer, you're going to see slightly less than X in mesothelioma. That's just the unfortunate reality of the situation. But we are still seeing successes, and that's a good thing. And mesothelioma has had even less success than many lung cancers. So the fact that we're seeing anything at all is really exciting. It's a really nice thing to do. Even if right now in the UK, we don't really have anything in this field today. I think, yes, sometime next year, I would be optimistic and hopefully seeing some sort of change there. And hopefully for the next few years, even more again.
Alex, it's great. Great to talk to you. I can feel your enthusiasm. You're our first pathologist that we've interviewed, and it's great to have your take on it, and really be at that cutting edge and trying to explain it to the whole of our mesothelioma community. It's great. So
no, I'm delighted to. As I say, it's nice to give a talk on mesothelioma and for once actually have some positive things to say in terms of the future.
I mean, we talk about the steps forward we've made. If you look at our requirements for pathology input and the differences and the recommendations that have been made by the National Mesothelioma Audit, and making sure that we really reach those targets of having pathology in our MDT, that we have that expert opinion and that we can push forward that way, and where that's not being met in some multidisciplinary teams, that we really recommend that that improves. And I can tell, as I say, from your enthusiasm that things are improving generally in the field of pathology in mesothelioma, and I'm really grateful for that.
Absolutely. I mean, I think it's an exciting time. I think it's an exciting time for pathology. Pathology gets a little bit of a bad rep sometimes of being a little bit backwards thinking and dark rooms. Actually, I am in a slightly dark room, but that's That's bye. We are seeing lots of these new things come along, and I think what's really exciting, just generally speaking, is this sort of transition away from and research and big pharma attempting to apply one-size-fits-all model to very, very big groups. You know, you say mesothelioma, but actually that represents a very diverse range of different cancer types within the context of mesothelioma. By looking at different biomarkers, we were able to start teasing these apart a little bit more, and we actually have some treatments to go alongside with that. So I'm biased, of course, but yes, I think more pathologist input is a good thing at MDTs, and it helps to explain what these differences are and help to come up with that treatment decision. And it's nice for me as well, because again, as a pathologist, I don't have an awful lot of face-to-face patient contact. And so it's nice to be in that situation where you can see the decisions you're making having that tangible benefit. And it is nice to be able to say, no, we have treatment options, there will be treatment options becoming available, and you know, this will tangibly improve the life of a patient who has, you know, these terrible diseases.
Thanks. Dr. Alex Haragan, thank you very much for joining me today, and I hope to speak to you again soon. Bye-bye for now.
Absolutely. Thank you very much. Bye-bye.